Hello, everyone, and welcome to our 2023 IM Bootcamp. We are so happy that you guys were all able to come register and join us with our fabulous Yale IM residents who have dedicated their time to giving us some tips and tricks for preparing us for success today. Just some quick notes. There will be question and answer time at the end, so please refrain from interrupting during the actual presentations. If you guys have any questions, you can type them into the chat instead. The other thing is we'll send a survey out during an intermission, so please fill that out just so we know how to constantly improve these bootcamp sessions for you. And then finally, there will be a recording of this session for paying APAMSA members. So if you guys do want access to this, please make sure to sign up and register as an APAMSA member. And with all that, I'm going to hand the mic over to Rui.
Thank you so much, Victoria, and Jerry for organizing this on behalf of the APAMSA National Board. I want to welcome all our medical student and recent IMG medical student grad friends coming from 37 US states today. We've put together a very packed and high yield set of practical sessions ranging from how to call a consult, how to run a code, ACLS, to inpatient insulin management and point of care ultrasound, both based on our experience with incoming interns as well as feedback from last year's session. We also have a half an hour session at the end where we're happy to talk about any topic of your choice. There will be a 5-minute intermission, as Victoria mentioned. And if you have any questions, please type it in the chat box. Feel free to ask anything you want, and the remaining 4 residents who are not presenting will try to respond to you during the sessions. So I wanted to introduce you to the 5 residents from Yale who are not only master clinicians, but also master teachers. I've worked with every one of these residents personally as a fellow, and they are just terrific. Myself, I'm Ray. I'm a cardiology fellow currently at Yale. And I was very involved with APAMSA. I was the national president from 2016 to 2018 and have continued to stay involved as part of the alumni advisory board. I will pass it on to the speakers in the order of their speaking. First up is Akash.
Hi, everyone. Akash. I'm a third-year resident at Yale. I'm from Louisville, Kentucky. I did my college and medical school at Louisville. And then I actually was an ophthalmology resident before internal medicine. So I did a year, a transitional year in Columbus, Ohio at a community hospital, and then was at NYU for a year and a half in ophthalmology, but missed internal medicine so much that I wanted to switch. So I did a year of research, went back through the match. I've had the fortune of working with great people like Ray at Yale. I have a passion for education. So I'm doing the clinician educator distinction pathway. And then I've done research in a lot of areas like Lyme, COVID, and still have some interest in ophthalmology where it intersects with rheumatology. So I've done some research there and hope to continue that at Penn, where I'll be doing rheumatology fellowship. My hobbies outside of work, I love food. So Indian Thai food are 2 of my favorites, and I'm a pretty avid tennis player.
Thanks, Akash. We have Sanju.
Hey, I'm Sanju. I am from Aurora, Colorado, and I went to the University of Colorado for literally everything, from undergrad and med school. Decided it was time to switch things up, which is why I came out to the East Coast for residency. So I am a traditional internal medicine resident. I'm in my 2nd year here. You can read I'm involved in a few things here, and I am going to take a year off and then apply for cardiology fellowship next year. Outside of work, I've been pickleballing, which is fun, playing board games. I just love to go to coffee shops and day trip around the Northeast. That's me.
Thanks, Sanju. Arsh.
Hi guys, my name is Arsh. I am born in Los Angeles, California. I went to USC for undergrad and Penn State University for med school. I am in the IM program as well. Hopefully, maybe I can apply to cardiology.
Sorry, it looks like Arsh got cut out there, but Arsh is an excellent PGY2 here at Yale, and he's applying to cardiology fellowship next year. Miles.
Hi, everyone. I'm Miles, one of the third years at Yale. I was born and raised in Redwood City, California, and then subsequently went to Princeton with Ray for undergrad. Then I went to medical school at Rutgers, New Jersey Medical School, and then joined Yale for internal medicine residency, where I am one of the resident procedure team leaders. And I will be staying on as a cardiology fellow this year. And outside of work, I have two cats, Mr. Bean and Luna, who are very fun. I'm married to a pediatrics resident. We couples match together. And I'm very passionate about photography, interior design, video games. So yeah.
Thanks, Miles. Isa.
And I'm not Isa, but I will be introducing her because she'll be joining very shortly. But Isa, her hometown's Philadelphia and Orlando. She did her undergrad at Yale University and then subsequently went to UCSF for medical school and then transferred to Yale School of Medicine partway through, and then joined the Yale Internal Medicine program thereafter, where she is also on a clinician educator distinction pathway. She is also one of the leaders for a resident procedure team. She's a leader on our wellness council, and she's also passionate and actively involved in various GI and hepatology research projects. She's also going to be staying on as a Yale GI fellow this year. Outside of work, she's married to a general surgery resident. They couples matched as well. She has a fur baby, Ollie, who's the cutest dog ever. And she is a passionate, avid hiker, baker. She also loves interior design and art.
All right, thank you. Akash, take it away.
Sorry, give me 1 second. All right. Oop. The wrong slide. Don't know why that popped up. There we go. Can you see my slide? Perfect.
Yep.
Okay. So I'm going to talk first about how to call a consult. That's something that I was very scared to do when I was an intern. When you call a consult, I like to break it down and think about it in terms of 5 C's. So the 5 C's are contact, communicate, having a core question, collaborating, and then closing the loop. So I'm going to talk about each of these and then give a couple examples, both on the slide and just from personal experience about how to call a consult. So the first thing you'll do, regardless of like consult or just even when you talk to a nurse, is say your name and what service you're with. So I would say, I'm Akash, and always when you're talking to one of your colleagues, I think it's good to use just your first name. You don't need to say like your doctor so-and-so. It just, creates a little bit more of a relaxed atmosphere. So you want to say the name and what service you're on. So I'm Akash with general medicine, or I'm in the CCU or in the ICU. And then you want to say, when you do the communication aspect, you want to say what your consult question is, what the patient name, what their medical record number is or where they're located, and then a brief synopsis of what's going on. So core question and communicate I kind of lump together. So for example, I would say, the reason I'm calling you today is I'm concerned about this patient's chest pain. I'm not quite sure what's going on. And then you'd be like, Mr. Smith is a 65-year-old guy. He has hyperlipidemia. He's had strokes. He came in with this chest pain, couldn't breathe. We got an EKG. I'm concerned there's maybe some ST changes. His troponin was positive. We're not sure if he should be capped. So in that example I gave, I gave the one-liner of the patient. I gave things that were pertinent about the history for cardiology, right? So the chest pain, I did, a basic things that like an internal medicine intern would do, which is, like EKG, troponins, and then you have an actual question for them. Does this patient need a cath? And so then, you ask your consultant, what are your thoughts? So that's kind of collaborating with them. And sometimes they can give you some preliminary recommendations on the phone. Sometimes they'll be like, oh, thank you for that consult. This is a patient I'm concerned about. I do think they may need the cath lab, but let me take a look at the chart. So that's kind of collaborating with your consultant. And then closing the loop is, you give them time. You let your consultant do their work. They talk to their attending. They're going to see the patient. And then always, when they call you back with their results, just thank them for being involved in the patient care. So that's kind of one example, like, that I've had to call consult for. And then you can kind of see this one on the slide that, our med students here, for example, they even call consult. So this one says, I'm John Doe. I'm a 4th year working with Dr. Smith in the ER. With whom am I speaking? And then here's the patient, Miss Doe. They mention a one-liner, she's 24, asthma exacerbation. Here's kind of what's going on, mentions, physical exam wheezes. We've begun this. And then, this patient they're a little bit concerned about. So they ask, the consultant, can you evaluate her for admission and possibly, what to do for asthma? And then the consultant says, sure, maybe get a chest x-ray to look for infection. And then, you give them time and then you thank them. And then, the consultant closes the loop with continue her meds, order a chest x-ray, see you in about 20 minutes sort of thing. So those are kind of the steps. One thing I will say is, consultants, when they're more on the surgical aspects versus the, more cognitive fields, sometimes, if it's for a procedure or something, your one-liner or the information about the patient will be a little bit less if it's something like they need a kind of line or something like that. So you will kind of tease this out depending upon who you're calling. Like calling rheumatology where you don't know what's going on or infectious disease is very different than calling, interventional radiology to put in a Hickman catheter or some sort of line for a patient needing dialysis or something like that. So you'll kind of triage this. And it's always nice too, when you talk to your consultant, just even to ask for feedback about how to call the consult. So that's kind of my spiel about that. I'm going to move on. I'm doing the next topic. So I'm going to talk about one of the other things that came up a lot when I was an intern is when you're on night shift and you're covering lots of patients, just common things that come up for patients you're cross covering, which means patients that you may cover from another team or multiple teams. So nurses will often call you for a lot of things. So I'm going to go through some of the main things that were the top things that nurses would ask me about. So one call we get called a lot about is for insomnia or patients that can't sleep well at night. So the first thing is, you have to assess the cause. A lot of times it's, being in the hospital, patients get woken up, they're getting vital signs, there's a lot of noise. So sometimes medications that patients use for sleep at home, they're not carried over. So you want to see if patients are on anything at home. The reason I bring this up is, one thing we try to minimize in our older patient population is benzos or non-benzo sleep aids like Ambien or Zolpidem, things like that. I try really hard not to give those, but if those are chronic meds that patients have been on for a long time and they're not altered, then I'll look to see if they're on it and restart them on that at night. Otherwise, melatonin is great. 6 milligrams is usually the dose that we like to use. And usually want to give that 3 to 4 hours before they sleep. So usually around like 5, 6 p.m. if you can, just because it does take a couple hours to help with sleep. And then trazodone also has an off-label use for insomnia. So we'll sometimes give 25 milligram or 50 milligram for patients. Another common call from a nurse we get whenever we're on nights is about agitation. So I think it's important when you get this call to ask what they mean by a patient being agitated, because somebody refusing to go to sleep or being delirious is very different than a patient who may be violently aggressive or threatening staff. So the first thing, especially early on, I think it's important to go assess the patient, try to see what maybe could be causing them to be altered or a little bit different than their baseline. And that's, what kind of delirium is, ruling out any causes. Try to reorient them. If it's something as simple as sleep, you can use some of the medications we talked about for insomnia. But if the patient is aggressive, threatening staff, cannot be reoriented, then you may need to think about some low dose medications for like antipsychotics. And for these, always see if there's an EKG on file within the couple days. If not, check one. And then some of the medications I like to use, there are a whole host of them listed here. Seroquel is one of the go-tos I like. A low-dose Haldol as well. Again, making sure the EKG is okay. Hydroxyzine can be used. It's one of the medications that's a non-benzo anxiolytic. Ativan, Xanax, I'll sometimes use if QTCs aren't very safe for me. And I don't feel comfortable with some of the other medications, so I can give a very low dose. And then if patients can take oral, that's ideal. But if not, then you may have to consider IV or IM. The last thing I wanted to talk about was constipation on this slide. So again, if patients don't have a bowel movement, this will be a cause. This will be something you get called about. So first, assess the cause. It's okay to go examine the patient, particularly if they're not passing gas. If they're having, abdominal pain, go see them. If you're concerned about an obstruction, some kind of ileus, you may need an image. And kind of the dogma in medicine is for some of these things, try oral first. So oral, and you can see some different laxatives listed here on this slide. If they can't take oral, see if the patient's amenable to a suppository. So that's from the other end, or an enema as well. One of the go-tos I like are Miralax and then Docusate Senna. Those are the two I usually start with. Lactulose is great too. Some patients just do not like the taste of it. And then mag citrate, it can cause some spasms and it stimulates a lot of the movement. So each of these are different types of laxatives. Some are osmotic, some are stimulant. So mag citrate is like very, very last line. And I don't think our hospital even has it on formulary, but a lot of surgery residents may use that. So just something to be aware of. Nausea is another thing we get called a lot about. So similar to agitation, check if there's a QTC, go assess the cause. First line, I like Zofran, oral if they can take it. If they can't, give IV. And you can give this every 4, 6, 8 hours. Promethazine is another one. Compazine as well. These are two. They can be a little bit more sedating. Reglan is another great one, particularly if patients have history of nausea and they want to try a GI cocktail, that can be given. So that's like Maalox, or you can sometimes use like a PPI or H2 blocker with a little bit of that as well. So just something to keep in mind. Cough, congestion, we get called a lot about that. So again, assess it. Did a patient aspirate? Look at their vital signs. Is there some sort of infection brewing? And then just things we like are Robitussin, Tessalon pearls. The idea being that we're trying to help, the patient get it up. So these sort of break down the mucus. And then itchiness, we get a lot of calls about. Again, go assess it. Is there a rash somewhere? Is this new? Could this be related to, their bilirubin being up? Is there a new medication that may have caused them to have a rash with the itchiness? So go assess. Some patients have malignancy. It can be a side effect of medications. And then usually I like Atarax for these patients, or hydroxyzine for that, give them oral. Sometimes a low dose antihistamine like Zyrtec. And then some patients, if they're younger and, you're not too concerned about Benadryl, you can give them. But again, caution with Benadryl because it does have other anticholinergic and other side effects that can affect mental status. The last thing I wanted to talk a little bit about was pain. This is a common thing we get called about. So kind of the theme that you're seeing with each of these is, and I think it's very important early on, is assessing pain and what the degree of that. So go see the patient. Is this somebody who sort of has new onset pain? Is this somebody that has cancer and they have underlying pain at baseline, or sickle cell, so acute on chronic? Or is it some sort of inflammatory process in the body like pancreatitis? So headache, you may triage a little bit differently. The patient tells you 2 out of 10 as opposed to 10 out of 10 for pancreatitis. If it's a localized area, topical agents are really great. So lidocaine creams, lidocaine patches, I really like those. Voltaren or diclofenac gel as well. And then sort of there's the stepwise approach I like to think about pain. So Tylenol is great. You can start with that. It's great medication. You can give up to, 3 grams, 2 grams if they have, liver disease, cirrhosis, that sort of thing. And then, NSAIDs like ibuprofen, things like that, assuming there's no renal or GI contraindication. For moderate pain, that's where I start thinking about things like tramadol, which is a weak opioid, oxycodone's opioid. And then if it's somebody severe pain, so thinking again back to like my pancreatitis patients or my cancer patients or sickle cell crises, these are patients I have a low threshold for like hydromorphone or morphine. And again, if they can take oral, that's great. But if they're just nauseous or unable to, then you may have to think about IV, IM, or subcutaneous. So here's a slide I'll leave up here for a second. And one thing that you'll see is that there's a lot of medication. So sometimes it's hard to think about, how much stronger is one medication versus the other. So I kind of like this graphic. And the moral of this graphic I want to kind of lay out is sort of that tramadol, oxycodone, I think of as my lower potency. And then like opioids sort of, and then morphine, Dilaudid, these are more stronger, Dilaudid's hydromorphone, and then fentanyl, patch. This is very, very strong medication. IV, I almost never do, on the floor. That's something that you would do more in the critical care setting if somebody's very, very sick. So I've never used fentanyl really on, a floor other than in the intensive care unit. And again, that's for somebody like, let's say I have to cardiovert or something like that. So I'm usually thinking about that, for very, very extreme circumstances. But tramadol, it's about 1/10 the potency of morphine, just to give you a sense. Oxycodone, you can kind of see 1.5 stronger. PO Dilaudid, it's 5 times stronger than morphine. So more on the day shift side, but a lot of times you may think about converting things to morphine equivalents. So that's the reason I put this up here. And then again, IR, ER, these mean intermediate release or extended release. So at night, you'll be giving more of the short acting or immediate release medications. The extended release will be more something the daytime doctors will do. And those are usually twice a day or 3 times a day. And hydromorphone, again, is the stronger. IV versus oral, I kind of, have to really triage the patient for that and sort of what's going on with them clinically. And then just some caveats. So if patients have renal disease, Dilaudid is preferred because morphine, the metabolites will accumulate if patients aren't able to excrete it out. So Dilaudid, that doesn't happen as much. So that's an instance where I would jump to Dilaudid. And then patients that have cirrhosis, liver disease, Issa will be talking much more about liver disease, cirrhosis later. This is very challenging. And that's because a lot of these medications are cleared by the liver. So they can accumulate and increase the risk of hepatic encephalopathy. So a lot of times, honestly, like Tylenol and lidocaine patches are sort of what you're limited to. Tramadol, it can be used if you look at guidelines, but some attendings may not like that. So very, very cautious with that. And you can kind of see the doses here. And then if it's neuropathic pain, that's where you think about your gabapentin, your pregabalin, and even nortriptyline can also be used as well. And then I just want to talk a little bit about fluids very briefly here. So fluids may be something you get asked to do at night. It's important to think about your fluids, crystalloids, in terms of, is it isotonic, hypotonic? These are 2 of the more common ones you will use. So isotonic, lactated ringers is LR, normal saline. Lactated ringers is more physiologic with the body. We tend to use that more for sepsis, things like that. Normal saline, patients that are hyponatremic. Probably you remember learning in medical school, there's about 154 milliequivalents of sodium and chloride in normal saline. Hypotonic is half normal, so it'd be half of that. And then hyper, these are, more for your patients that like 3%, that's something you would do for patients with significant hyponatremia. D5, so that's dextrose with half normal, or D5LR, so dextrose, lactated ringers. These are more for maintenance. If you need pure free water specifically, that would be D5. And then there's D10, so that's dextrose, and D5, D10, that tells you the percent of dextrose. So D5 is 5%, 10% is D10, for example. And then D50, which really that's something if somebody's extremely hypoglycemic, you just give a little bit of that. And then albumin, is more colloid. This is something you'll use a lot for your patients with cirrhosis that have certain criteria they need, like they're hypertensive, they may have, renal issues, things like that. And when you're on the floors, especially at night, sometimes you have to ask yourself, do patients need like maintenance fluid? So this is to replace daily losses. So when patients, perspire, keeping things, at maintaining their ins and their outs. So what they take in, what they take out, and that you'll, figure out depending upon how much they weigh and things like that. So you can kind of see some examples here for pancreatitis. You give a little bit more, but just for like your 70 kilogram, 60 kilogram kind of person, 100 milliliters an hour usually is how you'll run that. And then patients that need more intermediate fluids, so that's called bolusing, where you give a lot at once. So you may give like half a liter or a liter over an hour. And these are patients that you're worried about going into shock. Are they septic? Are they bleeding? Are they burns? And so you can kind of see an example here. And then again, you have to triage for the patient. So somebody who has heart failure, you're going to be a little bit more cautious. You may do smaller quantities as opposed to, if somebody doesn't have that, they're younger, then you can give them a little bit more. So next I'm going to hand it over to Arsh so he can talk about how to run a code.
Hi guys, Sanja's going to be nice enough and share her screen for me. And I'll be talking about exactly how to run a code, ACLS. If we can go to the next slide, that'd be great. So before we talk about like code blues, I really wanted to talk about like how to ask about code status. This is usually done when you admit patients to the hospital, and it's part of like kind of the mission order set of, what is a patient's code status? Asking these questions can be kind of awkward and kind of throw patients off. Sometimes they cause a lot of anxiety. So definitely like try and normalize the line of questioning. Like we ask all admitted patients this, it's required by the hospital. And that kind of helps normalize the situation and kind of like gets rid of some of the anxiety that patients might feel when you're asking them, what happens when your heart stops? What do you want us to do? I definitely recommend like using simplified terms because people don't always understand what like cardiac arrest means or acute hypoxic respiratory failure means. So like simplifying into like, if your heart stopped and you died, like, would you want us to do chest compressions? Or would you want us to shock your heart back into a normal rhythm? Or would you want us to put you on a breathing machine? And definitely like going in and explaining kind of what each intervention is in simplified terms definitely kind of helps. Helps the patient kind of understand what's going on. If patients decide not to be a full code or they decide like, I don't want chest compressions, I definitely think like asking about specific interventions like shocks, intubations, non-invasive ventilation or pressors is also important because there's a lot of things that we can still do to keep people alive without necessarily putting them through a full code. And then always, document whatever the patient kind of says about this, because it's really important for other providers to kind of know in these kind of acute situations what the patient would want. If we can go to the next slide, that'd be great. So kind of the basics of a code and being a code leader is like introduce yourself, be loud, be clear, be concise in your communication, and assign roles early. This diagram is what kind of comes from like the ACLS AHA group and what they recommend for roles. And I do something similar when I have to run codes. You're the leader. Stand at the foot of the bed. Be clear and concise with your communication. Assign a timer, someone who's timing what's going on. Assign someone who has dealing with airway, which is usually a respiratory therapist, and they usually come to all codes. Assign someone who can give meds and get access for you. And then, assign people who can do the actual chest compressions. And usually you need to assign more than one or two people because it's very tiring. And then I always have someone, which isn't in the diagram, holding the pulse at all times. Just so when we do get pulse, when we do stop compressions, we know right away and we can start going through other management options for them. Other things that I think about when I first walk into a room that there's a code going on, I make sure like the code status is known. If this person is full code and we're doing something that they would want to happen when they did have an arrest. And then the three things that I try to, get out of the way before going into all my thoughts about what might be happening is, does this person have a backboard? Is there pads on their chest? Is the pads connected to a defibrillator? Is there IV or IO access? And then I have people, call the primary team, and if appropriate, have someone, let the family know what's going on. All right, if we can go to the next slide, that'd be great. Kind of the next part of the code blue is the algorithm. The algorithm is split up into kind of two sort of sides here, whether you can kind of shock someone or you can't shock someone. Otherwise, the algorithm is kind of the same on both sides. You do CPR for 2 minutes, you stop, you do a pulse check. I give people 5 seconds to find whether there's a pulse or not. So it's really important to give people time to kind of find it. It might take some time. And then you're analyzing the defibrillator, which shows you the rhythm that the patient is in. And you have to decide then whether it's a shockable or non-shockable rhythm. And then you go back into, if it's shockable, you shock. If it's not shockable, you don't shock. And then you go right back into compressions. And then you do that for another 2 minutes, and then you check a pulse. And between that, every 3 to 5 minutes, you're giving epinephrine, 1 milligram. The way I think about it, because sometimes the math can get hard in your head, is that, every 2 minutes you're doing a pulse check, every other pulse check you're giving epinephrine. And that goes in between that 3 to 5 minutes. Now, I quickly want to talk about analyzing rhythms. So asystole is, what you guys, I'm sure, know at this point, is that it's basically there's no electrical activity coming from your heart. So it's a flat line. PEA is pulseless electrical activity that's coming from your heart, and it kind of just looks like a normal QRS. And that QRS is not tachycardic, and it doesn't really, it's not a shockable rhythm. And it's important to distinguish that from kind of your ventricular fibrillations and your ventricular tachycardias, which is that third rhythm on the bottom there. Fibrillation is this very fast electrical activity that goes up and down. It looks irregular, and it looks like polymorphic. That means each kind of QRS looks different from the one next to it. Ventricular tachycardia, which isn't on here, is a wide complex tachycardia. So it's a very fast rhythm that has a wide QRS. And you shock these rhythms back into a regular rhythm for the heart to kind of beat normally or have a normal electrical activity. So just kind of understanding the importance of the rhythms and making sure you understand kind of the 2 minutes of CPR, then pulse check, and every 4 minutes kind of giving epinephrine really kind of helps you do the basics of what you really need to do during a code. And I'll tell you why in the next slide. Because, and it's important to know the kind of the algorithm, because there's a bunch of things in the code cards, and these situations can get very tense, and there's a lot of people in these rooms and a lot of people outside the rooms kind of shouting and yelling what to do, right? But I think it's important for code leaders to kind of know that there's 3 things that we have evidence for that really help during codes, and that's chest compressions, that's giving shocks, and that's giving epinephrine. Those are the 3 most basic things that have proven to get ROSC and improve mortality. The other 15 to 20 things that people have in code cards, like sodium bicarb, calcium, magnesium, amio, lidocaine, the evidence is much more limited in their ability to get ROSC and improve mortality. So when you're going in as a new code leader, it's important to know that you have these things in your medication drawers, but the 3 things that you really need to focus on are the 3 things that we just talked about. Briefly, I'll mention, amio and lidocaine are used for, when you have someone in shockable rhythms, it's important to give amio and lidocaine because that can help break those arrhythmias. Epinephrine, we already talked about, and sodium bicarb. It's a highly debated issue among physicians about the benefit of sodium bicarb during codes. And personally, I tend to give it when codes go on for a long time, greater than 5 minutes, or when someone has an unknown downtime. These kind of other things, calcium chloride, magnesium, are things that I particularly think about in renal patients when these patients end up coding on the floor. All right, next slide. So, next steps, once you've kind of established, the roles, you've established yourself as leader, you've kind of gone through
a few rounds of CPR, I think about kind of next steps of what I need to do for my patient in this situation. So I kind of think about what the causes are. I kind of go in my head through the H's and T's. And, there's only a limited amount of things that we kind of think about when we have a patient who undergoes cardiac arrest. Hypovolemia, hypoxia, acidosis, hypokalemia, hypothermia, tamponade, tension, pneumo, thrombosis, PEs, or toxins. Trauma and hypoglycemia are kind of from the older lessons that we've thought about when sometimes people have cardiac arrested, but these are actually taken out of kind of the ACLS guidelines right now. But these are kind of important things to think about when you walk into one of these situations still. And it's kind of hard to distinguish when you don't know the patient what these are between what's going on with the patient. So it's really important to kind of get the one-liner from either the nurse that's taking care of the patient or from like the primary team member who's kind of called you to this code. And that can give you a lot of insight to what's going on, right? This is a 94-year-old with cancer who, we stopped anticoagulation recently. PE goes a lot higher on my differential, what's going on. Versus, hi, this person has been having dysphagia for a long time. They're eating food and all of a sudden, like they kind of slumped over. Aspiration, hypoxia kind of goes up higher in my differential versus this is a renal patient who missed the dialysis session, hyperkalemia, acidosis become a little bit more important in that differential. So history can really lend you to identifying and kind of helping differentiating between the H's and T's. I always take a look at the recent labs because that can be a big clue into, whether this person was acidotic, hyperkalemic or not. Once, you kind of figure out a cause and once you start treating that certain cause during a code, you continue down the algorithm. Every 2 minutes you do 2 minutes of CPR, you do a pulse check, and you kind of trying to treat the underlying cause of what's going on as best as you can. And either you get ROSC or you have to call the code, which is also kind of a big deal because you're kind of saying that, medically there's no longer anything that, we can offer this patient. I recommend in these kind of sort of situations that, you take the time to, respect the life that's in front of you and respect everyone who's kind of coming to help, kind of help you. These are delicate situations and, debriefing after is super important, not only with, your team, but, anyone who was helping out in the code. If we can move to the next slide, that'd be great. So the big takeaways that I kind of want you guys to get from this is that, take lead, be loud, be concise, assign your roles, follow the algorithm, and remember, like chest compressions, epinephrines, and shocks are the most important things that you're in charge of when you're the leader, and those are the things that are going to kind of help you get ROSC. Closed loop communications, again, being clear and concise with your communications, and then don't be afraid to ask for help in these situations. Summarize what you've done, what's been going on in the code. But, there's nurses that have been working 20, 30 years on the floors and, have seen these situations a lot more than we have and can kind of help you come up with ideas of what needs to be done. There's a bunch of apps that people use. There was like an NGM app that, or MGH app when I was an intern that was free. I think it's no longer free anymore, but this Full Code Pro app is really great for people who get assigned as timers because it basically times everything you need to do. So definitely recommend, downloading this app before you start on the wards.
I realize I'm muted. I'm so sorry. Never have I ever thought I would do that. But yes, okay, it's my turn now. Let's talk about essentially shortness of breath. My name is Sanji. I'm a second year, like I said. I'm gonna keep it as succinct as possible because you can talk about dyspnea and stuff for a while. So this is just like the general overall approach. So starting with what even is the difference between dyspnea and hypoxia? Dyspnea is what the patient's actually feeling and it's their subjective sensation. It doesn't have to be an oxygen issue. It could be like a hypercapnic issue, but it's not something that like the nurse would be saying. It's just kind of what your patient is experiencing. Hypoxia on the flip side is the objective data. And so you can use their pulse ox, like what they're satting or their actual like arterial sat to determine if they're hypoxic. Okay, so it's easier to frame this in my opinion as like a case because this is what you're actually going to be called on as an intern. So if you picture this, a 53-year-old gentleman has this cardiac history, admitted a couple days ago with lower extremity edema and some shortness of breath. He has some weight gain. So he's probably here with some sort of like acute decompensated heart failure. He was diuresed with somewhat good effect. And then you're on nights, but you suddenly get a call about his SAT dropping to 84%. You go look at him, and he actually seems like he's dyspneic, tachypneic, and has an increased work of breathing. So your nurse is going to be like, all right, what do you want to do next? And that's when you have to kind of figure out your game plan. And so the way you think about it is like to assess the situation and act. And oftentimes you have to do this like simultaneously because it's not necessarily two separate issues, right? It's all happening at the same time. So you want to check their ABCs, number one, make sure they've got their airways intact, it's nothing, they're breathing okay, and like their cardiac status is okay. And you also want to get a full set of vitals because getting one vital singular isn't really helpful in determining what could be the etiology. And, typically you'll be like in the workroom or your call room or something. And so you can ask the nurse to grab that full set as you walk over. So right when you get to the room, you might already have a full set ready, and you can recycle everything to see if there's been a change in the last, 2 to 5 minutes that it takes you to get there. The next thing is to make sure it's an actual SAT, because I don't think we appreciate this as much, and maybe you guys do, but I didn't appreciate this much as a med student about like what a pleth is. But that's the actual like waveform that's you can see on the monitors when they have their pulse ox on, whether it's like their finger or their ear or their toe. And something that looks like really like low amplitude typically signifies low perfusion. That could be very real. It just is a lower perfusion state. And so you want to find a place where you have like kind of more reliable data. And then once your signal, like kind of your waveform looks like it has higher amplitude, you can kind of trust that a little bit more. So the first thing to do is just to put them on supplemental oxygen. And while you're putting them on oxygen, you can start thinking about, is this something that I need to fix right this second, or do we have a little bit of time? Because if their SAT dropped from like 93 to 91, you've got a couple moments to figure it out. But if it dropped significantly, you might have to call an RT, which is like the rapid response team. And you might also have to consider like intubation or escalating their care, whether it's to the ICU or get anesthesia involved, all things that your nursing can help you with. Around that time, you can also think about what diagnostics you want to perform. You can, get a chest x-ray, which will take some time to get up there, grab a gas real quick, figure out what the issue is. If it's just pure hypoxemia, is there a hypercarbic component to it? Check some lights, make sure they're not feeling this like subjective shortness of breath from like a brand new GI bleed that's causing them to be super anemic. You can also, start thinking about PE, and do you need to actually go down and get a CTA? And then we'll get to this a little bit later, but your handheld POCUS, or your POCUS that's on your floor, is super helpful in determining etiology as well. Okay. Around that time, as you're doing all these actions, you want to get the gears rolling in your brain to figure out what's causing this. And when I think about hypoxia or dyspnea, I think about like, where is it coming from? Heart, lung, or like something else. And something else is actually not too complicated. There's only a few other things that can affect your breathing. So we'll start with the bottom part. This is from the Clinical Problem Solvers, who, if you haven't gone to their website, they have like schemas for everything, which I think is really helpful. So this is the dyspnea one. And on the bottom, you have like actual anatomic changes. So this is going to be like chest wall issues. If they're obese, maybe at night they're getting dyspneic every night, and then you realize that they have OSA. It could be a heme issue, which we talked about already as well, or like psych issues from anxiety or like an acidosis. But the more common ones are on the top, right? Your cardiovascular and your pulmonary issues. And so around that time, it's kind of what Ursha's already said on the ACLS, is figuring out like, hey, why is my patient here? What could have happened? And if they're already here with a heart failure exacerbation, and then they're feeling short of breath, perhaps they need to be diuresed more. And so sometimes your patient just tells you what's going on. And in both pathways, it's just you have to think about the different aspects of the organ, the heart, and then the lungs, and what part of the lungs are being affected. And some of these things won't cause a rapid DSAT. If someone has ILD chronically, it's not like they're going to rapidly DSAT one night unless something else is happening, like an effusion on top of their ILD. So then, yes, a little bit of schema thinking. And then, like I said earlier, you want to actually give your patient what they're missing, which is the oxygen. And I really didn't learn this until intern year. I don't know if maybe I just like missed that day of school, but I feel like it's really difficult to figure out what kind of oxygen, because nursing will ask you, and then not just nursing, but you need to know what the next step is. And so there's two separate diagrams on this, but there's kind of the general flow of what you go from. So you start with a nasal cannula, and that's something I think most of us are probably familiar with, just, goes around the nose, has a flow rate of between, like, you can do like a liter, but typically like 2 to 6 liters per minute. And you get up to 40% of FiO2. From there, I'm just going to jump a little bit to the non-rebreather, because that's tends to be a very common fan favorite. Your flow can increase, and you have like this reservoir, which is that bag that you can see. I don't know if you can actually see my little doohickey here, but it looks like a bag. And your FiO2 can also go up as well, which is really helpful. After that, you can go to high flow nasal cannula, which honestly, if you look at it down here, it's number 4. It looks really similar to the regular nasal cannula. It still looks like it just goes into their nose, but it is robust. It has a super high flow rate, right? 30 to 60 liters per minute. And you can crank up the oxygen all the way to 100% on the FiO2. And then after that is your non-invasive positive pressure ventilations. This is going to be your CPAPs and your BiPAPs. Which are definitely more like hefty devices. Oftentimes these have to be initiated in higher levels of care. So if you're thinking about starting a BiPAP on someone, you probably want to start a rapid and get all the right members of the team there. And then the last one is an intubation, which is just mechanical ventilation, and the tube can't really do that without the help of anesthesia, oftentimes if you're in internal medicine. And so that's kind of your escalation of which different ways to get them oxygen. And then just like to review kind of overall, when you see your patient, right, you first want to see sick, not sick, stable, not stable. And if they're not stable and they need mechanical ventilation like 10 minutes ago, like that's the first thing you do. You don't need to check their gas immediately. You want to fix that issue. But then as you're actually able to go through things, you want to make sure you do your differential and a targeted exam. And then you can grab all the labs that we talked about earlier, looking for like a heart failure exacerbation. Is it a STEMI? Or do you need like a stat chest x-ray? And then you want to do the therapeutics, which is fix the issue and give them what they need, which is oxygen, and then take off whatever needs to be taken off. I think that's it. That's my approach to dyspnea. I'm trying to keep it nice and quick, so hopefully that's helpful. The next one, which is going to be the coolest talk, is the approach to heart failure, because the heart is the coolest organ. So talking about heart failure, it's first really important to figure out your classification. And I think oftentimes, at least even to this day, when I think about heart failure, it's really easy to just think about the EF and go, okay, is it up or down? And then go from there. But I think before you even go to that state, it's helpful to think about heart failure as a low cardiac output or high cardiac output. So we'll start with the right side of the screen for everyone. It's the high cardiac output state. And it's either normal or higher output because there's higher needs in the body for whatever reason. And that can be normal, right? In pregnancy, or if someone's like slightly hyperthyroidic, does that count? If they have hyperthyroidism or they're in thyroid storm, which isn't necessarily normal, they could have a higher output, which will then cause similar like heart failure exacerbation like picture. But the left side of the screen is the screen that I guess we think of way more often, right? Which is this low output heart failure. And that's the heart's just not able to keep up with the rest of the body. And this is normal exertion, right? So we'll start with the right-sided heart failure. Obviously, this is not just an American picture because edema is spelled with an O, but what you're thinking about is when it's in the right side of the heart, your backup is to the rest of the body. And so you're going to see, lower extremity edema. They're going to have ascites. Their liver is going to feel all congested, and then you might feel like hepatomegaly. And then because they have so much fluid everywhere, oftentimes your patients like feel ill. They feel nauseous and they can't really eat. And so in those situations, then you can think about where the backup is. And so that's going to be the most common cause would be like left ventricular failure or something in the actual lungs that's causing a backup. And then this middle part here is the left-sided heart failure. And this is kind of the ones that we typically think of, right? Like, is it a HFrEF or HFpEF, systolic or diastolic failure? and then helps to think about what is causing those. Now, there is a caveat with this. There's different ways to classify heart failure other than like this schema, which is just to think about the classification. So there's two ways. The first one is like the NYHA classes. And this is about really how the patient has symptoms and whether they have symptoms always, no matter what, or if it's symptoms only during certain activities, or there's really no limitations at all. They have no symptoms whatsoever. It's just they still have what meets criteria for heart failure. So that's going to be your class 1. Naturally, as you go up on the classes, the limitations also go up. And then the second caveat I wanted to include for this slide is how we think about heart failure in terms of the EF, because I think in med school, I learned it as just like preserved or reduced. But there is like some nuances in between. So starting from like this bottom red part, if it's less than 40%, the ejection fraction, that's your reduced EF. Between 40 to 50, we call it mildly reduced, like HEF-MREF, if you want to call it that. And then above 50, like if someone had heart failure with preserved ejection fraction that had gone down, maybe like they had a STEMI or something and it had gone down and like slowly started to recover again, we actually do call that HEF with or heart failure with recovered ejection fraction rather than calling it preserved still, which has implications for treatment. Okay, so next is the actual symptoms, and it's kind of what we were talking about before as well. If there's an issue with things moving forward and perfusion, or if things are being clogged up, because cardiology is literally just plumbing. It's actually so easy. And so if you just think about it as like a tube with little blocks in between, you can figure out where the issue is. So for forward failure, right, their heart isn't able to squeeze out what it needs to squeeze out. That's when patients also feel like fatigue. They might have ultraventation because of poor perfusion. And then in backward failure, that's when everything looks all big and bloated because it's all backed up. So this is going to be edema. You're gonna, if it's left ventricular, like backward failure kind of symptoms, you might have like shortness of breath, and then early satiety. And then the physical exam. So I had one of the chiefs like last year who told me, when you think about heart failure, you have to go in and like the first thing you do is you have to touch your patient. And so typically, right, when you are called in for like dyspnea or something, you go into the patient's room, and the first thing he recommended was like lift up the bed, like bed sheets, and like put your hands on the patient's feet and just hold for a moment, just see what you feel, because it helps to put them in the buckets of like warm, dry, warm, wet, cold, dry, and cold, wet. And this can kind of give you a little bit of a basis of what their like wedge might be looking like, what their cardiac index might be looking like, and you can actually have a much more targeted exam just by feeling what's going on. So starting with this top left quadrant, if they're well perfused and their lungs are nice and dry, they're going to be warm and dry. And then if they're well perfused, so they're warm, but their lungs are like have edema and backed up, they're going to be wet. And then the next part is more of like the shock kind of profile where they're not able to put out enough forward flow. So that's going to be when they're cold, right? And if they're cold and dry, that's good because at least they're not wet, but cold and wet's not so great. But you do want to think about how can we optimize their forward flow. And then cold and wet is when they have too much fluid, but also not enough perfusion. And that gets really scary. And it has a higher mortality as well. And so when you're actually going and assessing your patient, it's really important to think that depending on where that heart failure is, right versus left, their exam can be vastly different, right? I think when we often think about heart failure, we think about like fluid in the lungs and like, oh, we hear some like bronchi, but that's not necessarily the case for all patients. So you can look at like pulse pressure, you can look at their vitals, you can look to see if they have like JVP, which is always hard to find, but if you're able to look for it, that's always helpful. And then, like I said, just feeling and seeing if there's any skin changes. And then finally, once you're starting to actually act on the patient, it's helpful to think about why they came in with a decompensated picture. So this is from osmosis. If anyone uses it, I found it to be very helpful in med school. And I think I still like recall some of the things I learned when I think about patients today. So this one is like, different causes for failure or for decompensation, and the mnemonic is failure. I'm assuming most folks can read, but it's helpful to think about it in this sense of, is this something that happened to them because they did it to themselves, almost in the sense that perhaps the medication didn't come in time and so they weren't able to take their medications, or perhaps they had a change in their lifestyle, it's just Thanksgiving, or is this something that actively happened recently? Like, did they go into an arrhythmia, some sort of ischemia or infarction or infection, or is there a different organ that's failing currently that's causing this decompensation? Okay. Workup. So while you're admitting a patient or seeing a patient who's in heart failure, important to get all sorts of labs and doohickeys, I suppose. So starting with just a general CBC and Chem7 plus liver function, so complete metabolic panel, CMP. And then you can also check for someone's BNP, the NT-proBNP, which can help sometimes if it's more so the delta that matters. And so if someone was like normal forever and then they suddenly had a rise in their BNP, it's really helpful to determine if this is actually a heart failure exacerbation. But if someone's chronically high or they're on certain medications like Entresto, for example, it's not as reliable. Then you can check the lactate to see if there's end organ damage, similar with checking like renal function, liver function. And if they also have chest pain, you want to grab a trope. Helpful to get a chest x-ray in this picture as well, especially if you're hearing something on exam. I think it's really important to know, I want to clarify that for someone who's in heart failure and they're kind of like on the earlier side of their course where it's not like florid heart failure, your lymphatics actually get upregulated. And so patients might not actually sound that bad on exam because their lymphatics are working an extra time. And their chest x-ray also might not look horrible. It's really helpful actually to POCUS, and you can kind of get to that a little bit later, but sensitivity of looking at lungs is significant if you're looking for like B lines and stuff to see if there's any fluid. You can also look for the EKG to see if there's any ischemia or heart block that's new that might have pushed them into the heart failure picture. And then later on, you can grab an echo. It's not gonna, I mean, if you can do it at bedside, Miles will teach you how to do that real soon, but if you can get a formal echo, that's helpful. And then assess for other etiologies, ischemic versus non-ischemic. Okay, management-wise, oftentimes the easiest thing to do is diurese, right? Like there's going to be extra fluid somewhere, most likely, unless it's hiding somewhere that you're not able to get it out without affecting their blood pressure. So if they're already on a home regimen, the easiest thing to do is double it and make it IV. Helps with actually absorbing the medication and making sure they reach that like threshold effect, which loop diuretics have. If they're Lasix naive, as we say, so they've never had it before, it's helpful to start with like IV Lasix 40. And then what you're going to do is just check their urine output for like 1 to 2 hours. You don't have to wait the whole 6 hours that Lasix is supposedly in your system. Wait a couple hours, see how much they've made. If they made like 500-600 of urine, cc's of urine, then great, like keep doing what you're doing. But if they haven't, just double it right then and there, spot dose them one more time and see where you can get before they actually respond to the diuretic. Give them oxygen if they need it, obviously. And then it's important to think about what medications that they're on that you should start, stop, like hold, that kind of picture. So if they have some sort of renal injury or they have a new AKI, you're going to stop those ACE inhibitors and ARBs and ARNIs. If their heart rate's already kind of slower, or if their blood pressure is on the slower end and their heart rate's compensating for it, you don't want to hold their beta blocker. It just depends on the situation. Similarly for the renal function, and depending on if they have like heart failure with preserved EF, you might want to stop NSAIDs and calcium channel blockers respectively. And then finally, not all these patients are just floor patients. I think it's really easy to think that they are. Some of them do need IV guided like vasodilators or inotropes or mechanical support for optimal diuresis. Okay, couple more. Hyponatremia is next. So we're going to switch gears over into renal world. This is it. This is really it. This is the slide that matters. It's a water issue, not a salt issue. I'm sure you've heard it only 1,000 times. Here's 1,001, but let's dive into it a little bit deeper. So it's important, really. I think this is tricky, hyponatremia, because there's just so many like slides on it and so many ways to memorize this thing, but it really comes down to like 3 pieces, right? Look at your patient, figure out what their volume status is, assess what their osms are, and then figure out if they're actually peeing out urine or peeing out sodium or not. And that's when you put them all together, you can kind of figure out what their etiology of their hyponatremia is. So we're going to go through this real slow-ish, and I hope it's helpful. But this is kind of the general approach to hyponatremia. So before even diving into this, it's important to see where their sodium actually is and if they're symptomatic. If someone has a very low sodium, like less than like 115 or so, and they're seizing, figuring out their etiology is not as important as actually fixing the issue. And so in those situations, they need to be in the ICU, they need to be on hypertonic saline, and that's a separate issue. So for this schema that we're going through is for someone who is stable with hyponatremia, and we can like sit down in the workroom and figure out what is the cause. So first thing to do is calculate or measure the serum osms, and you want to do this the same time that you check the urine osms, which will be later on, but just get all your labs done at once. This number should be between 280 to 285. So on the first side is going to be if it's high, which is hypertonic hyponatremia. So this is honestly quite rare, I would say, in terms of like when you're actually thinking about it. The only time that I see it often is glucose. So a lot of our patients come in with blood sugars in like the 200 to 400 range, and your sodium can get thrown off when your glucose is that high. So you want to make sure you adjust, and you can do that on MD Calc. You don't need to actually memorize the formula that's right there. But this is because there's other active solutes in their body that's causing that sodium to look like it's low when it's not actually low. The next step is when it's isotonic. So this is going to be if they have other proteins or lipids in the serum, which is also going to make it seem like their sodium is low. But the reason that it's not this hypertonic is it's, as you can see, neither protein nor lipids are part of that like osmolality calculation, but the sodium and the BUN, that kind of stuff is. Okay. The next part is where it gets, I think, a little bit more complicated, and this is your like hypotonic hyponatremia or true hyponatremia. So this is what I was saying earlier, where it's helpful to actually go see your patient, figure out their history, physical exam, and then check the urine lights, because that'll help you figure out, is the kidney doing what it's supposed to do in the situation that it's in, or is the kidney completely messing up? And that's really it. It's either doing its thing or not, and then you can go from there. So let's start with euvolemia, right? This is when someone's urine sodium is typically above 20. And you can break it into like the osms at this point. If their osms are high, like the little mnemonic is RATS, it's the one that I think about most often is SIADH. And so this is, syndrome of inappropriate antidiuretic hormone. So they are just holding on to all the fluid. The kidneys are doing what they're doing. They're getting like the signal that says, hey, hold on. And so this healthy kidney is like, all right, I'm going to hold on because someone else told me to. And from there, the solutes, just the urine osms, seem to be higher because you're getting rid of all the fluid, right? So it's more concentrated. On the flip side is primary polydipsia, or if they have chronic low solute intake, when their urine osms are going to be much lower. And in this case, there's just not enough solute to go around. So for whatever reason, either they're flushing it out with their system, or they're just not taking enough. Once again, your kidneys are doing what they're supposed to do. They're just confused because they're getting the wrong signal. These are typically reversible. You can fluid restrict. You can give them some more solute in the sense of like urea tabs or salt tabs. And it should be a really pretty easy fix. The next one is hypervolemia. And similarly, it's helpful to figure out if the patient has another etiology that's underlying that's causing them to be hypervolemic. So if they have heart failure, if they have cirrhosis or like nephrotic syndrome, and they're holding on to fluid, and we can see that they may seem anosarchic or just grossly edematous, then it's helpful to figure out like, is it what their urine sodium is? Is it because the urine sodium itself is going to be lower because it's just there's so much volume on the body, or is it an excretion issue? And in these situations, they just have to pee off the extra fluid, and then you want to also restrict a little bit, and then worst case situation, you might have to dialyze them as well. And then the last one, which I find to be the most common, but sometimes a little like mathematically, I guess, a little bit more complicated is your hypovolemic hyponatremia. And so in this situation, your urine osmoles are typically high, right? They just don't have enough volume inside. And then you think about what the urine sodium is. So we'll start with this renal side first. The urine sodium, when it's above 20, the job that the kidney is supposed to do is it's supposed to hold on to the salt so that it can hold on to the water. And when it loses that ability, you just pee out salt, right? So your urine sodium is going to be high. And for that reason, it's maybe you're forcing them to do that and you're giving your patient Lasix and you're wondering why their urine sodium is high, or it's because the kidney is just not working well. And that's an ATN or AKI kind of picture. On the flip side, it's extrarenal losses where your urine sodium is low because the kidneys are working. It's just that you're getting rid of sodium and all lights and fluid in a different way. So that's maybe you're vomiting, or not you, but your patient's vomiting or has diarrhea, or they're simply dehydrated. And in that situation, you just give them fluids. So that's my approach to hyponatremia. I hope that helps. It's really just looking at your patient. I think you'll figure it out from there. And then this is just like a easier diagram with fewer numbers, but it just kind of breaks it down from the volume status as well. I'm not going to repeat myself with this part. All right. Arsh, it's all you, my friend.
Okay, we'll take a very quick 2-minute intermission here. And I know we're a bit on a time crush. So if anybody needs to take a washroom break or anything, you can come back at 4:11. Welcome back from the intermission. We're going to change the order of a few things, and Sanju will tell you about point of care ultrasound.
All right. Hello, everyone. I promise I'm almost done and then you can be done with me. All right. So let's talk about point of care ultrasound, which is probably the coolest thing that we have, especially as internal medicine residents. I feel like we use it more than really anyone else. So there's a lot to it in terms of like the knobs and bobs, but we will go through all of it, and I hope this is helpful. So the first thing to think about is like the actual tools and the probes and what the probes mean. I'm going to keep this fairly simple. So we've got the three main probes that we use. There are other probes out there. There's also combined probes, but these are the ones that we use most often. The first one is the linear array probe, and then we have the curvilinear probe, and then the phased array. The other kind of layman terms that we use is the vascular probe, still curvilinear, and then the cardiac probe. And what's helpful with this is just figuring out which way the actual ultrasound signals are moving and what the frequency is. And it's helpful to think about how frequency affects your resolution and your penetration. So when you have something, let's go on this side first, right? If it's high frequency, it's going to have really good resolution, but it's not going to go very deep. On the flip side, if something is low frequency, it's going to have better penetration, so it'll go deeper, but it's not going to be as good in terms of resolution. And you can see on the bottom here that your highest frequency is your linear probe. So these are, like I said, the vascular probe, where you can't really see past like 5 centimeters, honestly. 2 to 3 centimeters is the best, but the resolution is phenomenal. And so that's what we use it for, like ultrasound access for IVs. And well, that's the biggest one. And then your curvilinear is really in the middle. This is kind of what we use for the abdominal. And then like the bases of the lungs, you can use your curvilinear as well. So when to use POCUS. One of our attendings here, Dr. Dunrow, he always says, do not do POCUS by anencephaly, which basically means is don't just throw a probe there and say, hey, we'll see what we see, because then you can kind of tell yourself that you're seeing things that aren't necessarily there. It's more helpful to have a very focused question and then put the probe on the patient. So if you see something on physical exam where you have a palpable mass, then you can say, all right, is this a cystic structure or a solid structure? And then you put your probe on, and then based on the echo density, you can figure out that answer. Procedurally, we use probes all the time in terms of like putting in central lines or even like peripheral IVs. For diagnostic purposes, it's helpful. You can look for stones in the gallbladder, which show up sometimes, but sometimes they don't show up as well. Or if you're trying to say, hey, do they have ascites, and you're trying to discern if you can do safe para or not, that can also be your focus question. And then finally, the multi-organ scan, and that's what we were talking about a little bit earlier in terms of figuring out what an etiology might be, and just seeing if you look for, if it's shortness of breath, you're going to look at the cardiac exam, the lung exam. If they have hypotension, you want to look at some of the vascular images as well. And so helpful to have a question and then go from there. All right, so there are movements. I'm going to use my phone because I feel like that's easier than actually just talking. So this is your probe. It's helpful to think about all the different movements that you might have. And so some of them are pretty standard, rotating, right? You just rotate. And then sweeping and sliding, those are a little bit confusing. But if you think about this like a broom, if you sweep, like no one really sweeps like this, right? Like you sweep on the long edge. And so that's going to be sweeping when you move in this direction. And then sliding is the exact opposite when you're moving in like the short axis. And then you have fanning or tilting, and that's like if it was a fan, right? And so you would fan like so. And then rocking is moving on the short axis, where you like your whole probe feels like it's like rocking, right? That one's the hardest one to remember. It doesn't make as much sense, but it's helpful when you're using those terms, especially for teaching and when someone's teaching you in terms of how to move your probe. The only one that's not on here is pressure, just putting more pressure on the probe. That's self-explanatory. And then so that next part is the actual orientation. So each probe will have a little indicator or a probe marker to figure out where that is in relation to the screen. So typically when you're doing procedures, you mark up, you match up the probe marker with the indicator to be on the left side when you're like looking at a screen, so that as you move your probe, it moves exactly the same way. The only time really that we use it on the flip side, or where the indicator and the marker and the indicator are both on the right side of the screen, or in the cardiac exam. And that's just the way it is. All right, so now I think this is what I think would be helpful, is just to go through what the actual screen shows and what each thing means. So these are different like little doohickeys that are on the actual ultrasound. And this is going to be for your like nicer ones. If you have like a butterfly, some of these aren't going to be there, but a lot of like the depth and gain, those kinds of things will. So starting with the application presets, I think these probes like the Sparks, for example, they already have a lot of presets where it'll match up that like indicator and where it's supposed to be oriented on the left or right. And so if you click like a cardiac exam, it's going to default to the right side. If you click lung, it's going to default to the left side. And then it'll also have the depth be kind of optimized. For example, for a lung exam, it'll try to go up to 15 because that's how much you need for an official B line to be called. And so it kind of does the thinking for you. The next one is depth, which I don't have a picture for because I feel like that's pretty straightforward. It's how deep you are. Next one is gain. And so this is going to be kind of like how bright your actual screen is. So in this picture, everything, I don't know if you can see my little pointer, but on the left side, everything just looks really dark. And so that's when your gain's down too much. And then on the right side, everything looks bright. And it's too bright because this vessel here has fluid when fluid is black, but you can see like white in it and it shouldn't be white. And so that's how you know it's too bright. And then just like Goldilocks, this is like right in between. You can see the structures nicely. They're pretty well delineated, but the actual vessel still continues to be black the way it's supposed to. So the gain is optimized. Then you have different modes. This is B mode that you can see right here, where you can kind of see like your basic screen. And then we use M mode as well. So that's going to look like this. Oftentimes there's just like an M, or sometimes it's an actual button on the screen that's an M. And this is going to be a way for you to like see kind of motion, and that's one singular plane, how things are moving. So this is what it could look like. This is M mode on the lung. And it's helpful to see if the lung has good lung sliding, and you can use M mode to do that. It should look like a beach a little bit in terms of like waves, and then you see like sand here, and that's how you know that you have good sliding. But if you don't have sliding, we call it a barcode, where it's kind of just like lines across the screen, just similar to what this looks like on the top. And there's none of this like pebbliness where you're actually moving. And then the last part here is the Doppler. I think this is everyone's favorite, but honestly, I find it to be the most confusing and the hardest mode that we use. We have different types of Doppler in terms of, different types of Doppler, but the one I'm going to talk about is pulse wave. And so it's helpful to figure out basically which direction there is flow. So red doesn't necessarily mean like arterial. It just helps you figure out, is there fluid moving towards your probe or is it moving away from your probe? And that just depends on which way you're holding your probe as well. That's all I've got, and that's all from me. So feel free to email or follow me on Twitter if you'd like to. I don't really tweet, but hopefully that helps.
Great. Can you guys hear me?
Yes.
Okay, awesome. Thank you. Excellent. So my name is Miles. I'm one of the third-year residents, and I'll be piggybacking off of Sanju's excellent intro to POCUS talk. And I'll be talking a little bit about bedside echo, which is a particular subcategory within POCUS. So let's get started. So bedside echo is really a quick and non-invasive way of assessing for a variety of things on your cardiac exam. So, systolic function, valvular function, intravascular volume status, which is really key, pericardial effusions, and many other pathologies. And my goal today is really to kind of just introduce you guys to the important cardiac windows, how to obtain them, and also to familiarize you guys with some of the structures that you're going to be seeing. So just a reiteration, there are several ultrasound probes that exist, but for the purposes of bedside echo, you're going to be using the phased array probe, which is a smaller probe on the right, which has the kind of smaller transducer head. As Sanju alluded to, it has lower range of frequencies, which means it will penetrate through more tissue in order to help you visualize deeper structures. And also that small transducer head allows you to get in between the ribs to visualize structures within the thorax. So let's begin. So again, just for reference, the green arrow on the probe represents the direction of the probe marker, and that corresponds with the P marker on the top of the screen. And so for your parasternal long axis view, this is the first view that we start with. As the name implies, you place your probe in the left parasternal region, and it's typically between the 3rd to 5th intercostal space, and you point your probe marker towards the patient's right shoulder. And here, you'll realize actually that all these names that I'll be going through corresponds to the locations and the orientations of your probe, which makes it a lot easier to remember. So in this view, we've essentially obtained a cut of the heart somewhat in line with its long axis, and going through the various structures, most anteriorly, we see the right ventricle up here. And then also posteriorly, we see the left atrium, which then leads to mitral valve, the left ventricle, the left ventricular outflow tract, the aortic valve, and then the aorta. And we can also see this shiny thing posteriorly is the pericardium. And also there is the descending aorta over here, barely in view. So overall, we see a pretty healthy looking heart with good squeeze, normal chamber sizes, and valves that appear to be opening and closing properly. So the next view that you can obtain is the parasternal short axis view. And to obtain this view, you keep the probe in the same position as your parasternal long axis, and you simply turn your probe marker 90 degrees towards the patient's left shoulder. And now you've obtained a cross-sectional view of the heart at the level of the aortic valve, which you can see in the center with its 3 leaflets. Again, you see the left atrium posteriorly, as well as the right atrium with the interatrial septum kind of coming into view, separating the 2 chambers. And we also see the tricuspid valve barely in view on the very left of the screen. And then we see the right ventricular outflow tract leading into the pulmonic valve and then the pulmonary artery. The next view is the parasternal short axis view at the level of the mitral valve. And to obtain this view, it's really simple. You keep the probe in the same position and you simply tilt or fan the probe head slightly towards the apex of the heart. And here you can see the crescent-shaped right ventricle, and then the circular left ventricle in its cross sections, as well as the mitral valve with its anterior and posterior leaflets. And you can easily identify the mitral valve because it looks kind of like a fish mouth. If you keep tilting down, you'll eventually get to the level of the mid-papillary muscles here in the screen. And then if you keep tilting, you'll eventually get to the apex of the heart. So the next view is the subcostal 4-chamber view, which is a really quick and easy way to assess cardiac function, and also is a great view for to look for any sort of pericardial fusions. And to obtain this view, the probe goes in the subxiphoid position with the probe marker facing the patient's left arm. And here you may need to apply a bit of pressure in order to obtain this view. So here you can see the 4 chambers, left atrium, left ventricle, right atrium, and right ventricle, as well as its respective valves. And then the bright structure up top is your liver. So the subcostal IVC view is a really important view that is commonly used in the assessment of intravascular volume status. So to obtain this view, the probe stays in the same subxiphoid position, and instead now the probe marker is turned up towards the patient's head. And here you can visualize the IVC coursing underneath the liver, draining into the right atrium right over here. And so the measurement of the IVC is then measured at rest and with inspiration or a sniff maneuver, and the collapsibility is also assessed. So here's some really important numbers to remember. So if your IVC diameter is greater than if the IVC is greater than 50% collapsible and the diameter is less than 2.1 centimeters, then this suggests that your volume status is lower normal with an estimated right atrial pressure of 0 to 5 millimeters of mercury. If you're greater than 50% collapsible and greater than 2.1 centimeters in diameter, or less than 50% and less than 2.1 centimeters, you're kind of in between 5 to 10 millimeters of mercury, or on average, we just say 8 millimeters of mercury. And then if you are less than 50% collapsible and greater than 2.1 centimeters in diameter, you are estimated at 10 to 15 millimeters of mercury, or volume up. And then the last important view I just want to go over is the apical 4-chamber view. So as the name suggests, the probe goes at the apex of the heart, typically between the 4th and 5th intercostal spaces. And the probe marker is facing the patient's left arm. And here we essentially obtain a horizontal cut of the heart, revealing the 4 chambers, the left atrium, left ventricle, right atrium, right ventricle, as well as its respective valves. And this is one of the really important views that are used in the calculation of left ventricular ejection fraction. And that's all I have. Thank you so much, guys.
All right, so as I begin to transition to my screen, just a shout out to Victoria's comment in the that anybody who wants a copy of the slides should leave some feedback. All right. Hello, welcome to Below the Diaphragm, part 2 of APAMSA Internal Medicine Bootcamp. Any questions here before I begin? Everybody pulling up the survey now? Excellent. Okay, kicking off with approach to GI bleed. You have been warned there will be poop. So the first thing you want to do when you're identifying the bleed is divide your abdomen into an upper and lower region. The cutoff point is usually called the ligament of Treitz. It helps to pin the small bowel against the abdominal wall. And anything above this ligament of Treitz tends to be an upper GI bleed. If it's brisk and coming out of your mouth, we call this hematemesis, that's blood out of the mouth. If it's a slow bleed that kind of works its way down the abdomen and then gets oxidized, it comes out tarry black, and that's melena. So the differential for here is GI tract damage, any erosive disease here, ulcers, esophagitis, GERD, or malignancies, varices, which are the dreaded complication of patients with cirrhosis, cancers, and very rare blood disorders. For those with lower GI bleeds, this is described as hematochezia. So that's more blood mixed in with the stool. So the stool is still usually brown. And the differential is diverticulosis, colorectal cancer, ischemia, and then hemorrhoids is classically described as blood streaks on the tissue paper. So it's not really mixed in with the stool, it's just when you wipe. You can identify different types of bleeds by patterns on testing, including a higher BUN on labs. Remember that high red blood cell turnover or bleeding can be identified with higher uremia. If somebody is reporting about a couple of tablespoons of persistent blood loss, or you're noticing a slow dwindling of their hemoglobin levels over a week of being inpatient, you can suspect a lower GI bleed or a slower bleed, which is melena. If you have hyperactive bowel sounds when you're listening, or you're actively aspirating blood out of an NG tube that happens to already be in the patient, you can be worried for bleeding. And then just wanted to say, you always want to do your own digital rectal exam to identify if there's blood in the vault, and then wipe your finger on a white surface to see if there's actually blood or if you're just seeing something. Here is your picture. Take a screenshot. Every intern needs a picture of poop on their phone to identify what is melena versus what is hematochezia, or just blood mixed in with stool, which separates out in the toilet. When you have a bleed, there are 3 steps. The 3 S's are stabilize, scope, and stop the bleed. Step 1, stabilize. Ensure you have access. 2 large bore IVs. Remember that a lower number gauge is a larger bore, so you can get more blood in faster. So a 16 gauge is actually bigger than an 18 gauge. Number 2 is you want to resuscitate. Get what you have. In most inpatient settings, normal saline or NS is all you have, so you're going to bolus first. As you're sending off a type-in screen, as you're ordering maybe a massive transfusion protocol or MTP, remembering that we transfuse from a hemoglobin greater than 7 or greater than 8 if you have ACS or acute coronary syndrome symptoms. You also have to think about if you need pressors to resuscitate these patients, they should be heading to the ICU. If they have a variceal bleeding, you're thinking about that breakdown of your mucosa from your bloodstream into your GI tract. So you need to cover with antibiotics that cover normal gut flora, and maybe start octreotide, which is the somatostatin analog that helps clamp down the blood vessels to stop bleeding. And again, to help heal erosions, you want to start pantoprazole or a proton pump inhibitor. Remember that pantoprazole is given as a bolus and then a drip, or you can do intermittent IV dosing, as was studied at Yale. For scoping, you're calling your GI fellow, which is me next year for those of you coming to Yale. If we're doing an upper EGD, or if we think that the bleeding is really just in the lower half, we might just do a colonoscopy or even just a flexible sigmoidoscopy, only looking at the latter half of the lower colon. And if we're scoping, we still don't know where the bleed's coming from, we might ask you to order a PillCam study or a tagged RBC scan to see if there's any bleeding that can be seen passively. And then when we finally identify the bleed, you want to stop the bleed. So a GI fellow or a GI attendant can do variceal banding, injection, thermocoagulation, or clipping. If it's a large area or it may be a malignancy that's bleeding, you're calling general surgery, emergency surgery, or even colorectal or surg-onc to surgically resect this bleeding. And if the patient is unstable, you don't have time to call me. You need to get a CT abdomen with IV contrast, and you need to immediately call IR at your institution to embolize. Next is the dreaded complication of patients with cirrhosis. It's decompensated cirrhosis. So why are we afraid of decompensated cirrhosis in the inpatient setting? Number one, you should not be afraid. You should say, I have the opportunity because I went and took this boot camp to help this patient understand the pathology. So patients with a hepatic venous pressure gradient greater than 10 are the patients who are at risk of developing into decompensated cirrhosis and the sequelae that I'm about to go over. These patients have a 50% of mortality if you do not help them in 6 months. So if you have decompensated cirrhosis, you may die within 6 months. Definitely may die within the next year or two if I don't do anything to help you. So that's why it's so important to know how to identify these patients and what to treat them for. So what do you have is the acronym I like to use in decompensated cirrhosis, HAVE. And so in my drawing here, Boards and Beyond style, H stands for hepatocellular carcinoma or cancer. A stands for ascites. V stands for variceal hemorrhage, which is your varices we technically think are more in the throat, but can also be in the stomach. They can be in the rectum. And then E is for encephalopathy or confusion associated with your liver not filtering out those toxins very well, and it just goes to your brain. How does this all happen? It happens because of increased cirrhosis, scarring, fibrosis in the most important organ of your abdomen, the filter, the liver. So if your liver is getting so scarred down, it can't filter anymore, then the portal hypertension goes up, increases resistance, and everything goes down after that. So sphinctic, your body will try to compensate by vasodilating. You're going to get third spacing or a hypovolemia effectively in your vessels. So it's going to third space to your abdomen, causing ascites, to your lungs, causing hepatic hydrothorax. Your kidneys are not going to see the circulation they need, so they're going to make you hold on to more salt, hold on to more water, making it worse. This is going to make your heart work overtime, increasing the cardiac output and flow, and it's just a vicious cycle. This then causes shunting to other organs, backing up, and swelling of your veins, which eventually pop, and that is the dreaded hemorrhage that you get. And of course, we know that as this filtration gets worse, you build up bilirubin in your blood, and then you turn yellow or jaundice, typically at a bilirubin level of more than 2.5 to 3. So how do we treat all these things? How do I save your life when I recognize that you have one of these sequelae of decompensated cirrhosis? For cancer, I'm going to screen you with ultrasound and maybe an AFP level. And once I diagnose something funny on ultrasound, I'm going to get a formal MRI hepatoma or a quadruple phase CT, recognizing that HCC and liver cancers are the only cancer that you do not need a piece of tissue of to diagnose. You can look at it just on a picture because it loves contrast. It will actually take up the arterial supply, whereas the rest of your liver takes up, gets a separate blood supply. For ascites, remember that fluid can third space anywhere. So you want to limit the salt, give diuretics. I know cardiologists love furosemide. Hepatologists like to combine it with spironolactone so you can balance out your potassium levels a little easier. You can do serial paracentesis. Less than 5 liters is a regular therapeutic paracentesis. 5 to 9 is a large volume para. And latest guidelines say you should not take more than 9 because you can actually fluid shift too much and hurt the kidneys and have post-paracentesis circulatory dysfunction. And then for patients who are really end-stage ascites and it's not helping, you might even refer them to TIPS, or transjugular hepatic portosystemic shunt, where we bypass most of the liver for that flow, which raises your chances of having encephalopathy or confusion. All right, so for encephalopathy, we're gonna grade it on a scale of 0. Hopefully you guys are more just grade 0 to 1, maybe a little tired right now. And then 4 is absolutely comatose, and I hope nobody is grade 4 right now. If you have presence of asterixis, which is trying to sustain a muscle contraction and has a couple of beats, it will be 2+ there. You're immediately at a 2 on the West Haven grading scale of 0 to 4. To minimize your chances of developing encephalopathy, you're going to promote a plant-based protein diet to increase albumin and fight sarcopenia or frailty, but you don't want to keep giving them red meats, which can precipitate uremia. You want to work up precipitating factors like infection, bleeding, sedation, shunting, not having enough bowel regimen, not pooping out enough of those toxins. And then in order to help prevent encephalopathy, you are obsessed. And these patients know that they should be pooping at least 3 times a day. When's the last time you guys pooped 3 times a day? Probably not unless you've been banging out the coffee for studying for steps. But if a patient has negative infectious workup, negative bleed workup, all these workup for precipitating factors are negative, and they're still sticking to their bowel regimen, and they're still encephalopathic, a little bit confused from their liver disease, you're going to bump them up to more bowel movements a day, even up to 5. And our cocktails of choice is either Miralax or lactulose with simethicone to help with the gaseous distension from lactulose. And if you really are recurrently hospitalized for encephalopathy with a good bowel regimen, you may even start a low-dose nonspecific antibiotic called rifaximin, which is extremely expensive. And last, we talked about variceal hemorrhage. I already covered it. In GI bleed, you got to scope stabilize. But if they have small or large varices, you want to start everybody on a non-selective beta blocker. These are your 3, if you don't remember what non-selective are: nadolol, propranolol, carvedilol, and you titrate it to a heart rate less than 65 for life. The idea is that if you keep your heart rate at a low rate, then those varices will never pop. And so once you see the varices, you start them on a beta blocker and you've saved them from ever needing to go to ICU for variceal hemorrhage. All right, guys, our last topic with me is how to start inpatient insulin. This is probably the one that really scares most interns, which is why I need to give you a warning that there is basic math ahead, but you're going to use a calculator and you're probably going to take a screenshot of this screen right now. So what are the types of insulin is the most important question you need to remember. Remember that in your normal body, your body in your pancreas likes to keep your sugars around 100, and it likes to, after eating, give you an insulin spike in order to help keep those glucose levels around 100. And so manufacturers have tried to create insulin in 2 general classes, the faster ones and then the longer acting ones, which have different names and different brands, but these are the basic ones that we use. And so your institution may vary, but you want to remember the different types here. There's Lispro, Aspart are the most common that we use that are rapid acting, and then Glargine is the most common long acting or basal insulin. And so a combination of having some long acting coverage with some short acting for meals really helps our patients on the inpatient setting. All right, so how do you start insulin in a patient with diabetes? Number 1, you need to get an accurate weight. So you need to weigh them immediately. At the same time in your institution, you're probably having a diabetes order set that includes how often you're sticking their fingers for point of care checks, the insulin sliding scale, and a hypoglycemia management to give them orange juice or dextrose 50, like Akash had said earlier, just in case their glucose levels are ever too low. Rule number 2 is you usually want to know how well controlled their insulin is overall. And so you're going to check an A1C, which gives you that snapshot of what their sugars have been like over the last 3 months, and to see if there are any home regimens prescribed, because that gives you a starting base of what to do in the inpatient setting. Rule number 3 is you don't try to predict hyperglycemia. You work with the previous day's data. So if somebody's just getting admitted with diabetes, don't try to predict how bad their hyperglycemia is going to get. Give yourself a day on a safer, more reduced scale, and then calculate from there, and you can always go add more insulin the next day. If the patient's having really complicated sugar highs and lows, it's okay to consult your diabetes team or endocrinology. This is bread and butter medicine, but sometimes there are really unique cases that are very difficult and complex. And then as a stylistic approach, decide if you're treating acute hyperglycemia or a chronic illness. A lot of senior residents like myself do not order diabetic diets. We like to order regular diets for our patients, even if we know they have diabetes, because we want to titrate to what they're going to eat and how they're going to be out in the community. And so unless this patient really knows what a diabetic diet is, perhaps that's a big contributor to why they might become hyperglycemic. But there are some patients whom diabetes is the reason why they're admitted. And so you're going to put them on a carb consistent or diabetic diet and be really closely titrating their sugars. And then you also want to ask, was their home regimen working? Was it expired? Is insulin expensive to them and they just weren't getting it even though they were prescribed the correct amount? Do they need access to needles? Do they need help with preparation of putting the needle into the bottle to drop their own insulin? And so if the patient does have a home regimen, you can just dose reduce it inpatient by 25% or 50%. Or if it's not working clearly and they're admitted for hyperglycemia, find a regimen and start from scratch that works for them. So how do you start insulin in a patient? Starting from scratch. Strategy 1 is low and slow. Take a screenshot of this right now so you have these calculations, because there is no way you're going to remember this right now at 4:45 on a Sunday afternoon. For long-acting insulin initial dose, you're going to take their weight in kilograms and multiply it by 0.2 if you want to low-ball it, 0.3 if you want to high-ball it. And then for short-acting insulin with the meals, you're going to take the same weight in kilograms and multiply it by 0.05 if you're going to low-ball it, or 0.1 if you're going to high-ball it. This is too much math for me. I like strategy 2, which is the basal bolus correction or easy dummy math kind of way. So what is strategy 2? What is BBC? Take the patient's weight in kilograms times 0.5, split that number into 2, half becomes basal and half becomes the bolus that you'll divide into 3 doses. What does this mean for a patient with 70 kilograms or 154 pounds? I'm going to take 70, multiply it by 0.5, that gives me 35 units total. I'm going to divide that by 2, half of it becomes long acting, half of it becomes short acting that I divide into 3 meals. That short acting into 3 meals becomes 5.8 units of short acting per meal. So this regimen is 17 units of a basal insulin and then 6 units of a short acting insulin per meal. For me, that would be 17 units of glargine and 16 units of Lispro. Common modifications for insulin regimens, remembering all the different types that we have. If the patient's NPO, nothing per oral, not eating, or tube feeds, or doesn't have regular meals, then you can't add a mealtime insulin for them. Change their sliding scale and their glucose checks to every 6 hours. Change the insulin sliding scale type to NPH, which is that intermediate acting, not too fast, not too long, and that will cover them every 6 hours when we're checking that sugar, whether or not they're eating or they're just getting tube feeds at a continuous rate. And then for long-acting basal insulin that they might be on at home, you're going to reduce it to 70%, and then they're not going to get the mealtime boluses if they're not eating for a procedure like endoscopy the next morning. If you have a concern for steroid-induced hyperglycemia, which we see a lot in the era of COVID because patients do get put on steroids for short periods of time, it depends on what steroid you're giving them. If it's short-acting, then you're going to use a 0.1 NPH per kg for every 10 milligrams of prednisone, up to 30 milligrams total. And if it's long-acting, which is dexamethasone, you're going to give them 0.3 units of NPH, so the higher end, or 0.2 units of their basal. And so you're not going to remember this. This is a lot of numbers. I just like putting on 2 examples for you guys. And the bottom run here is the most important, which is for if you're on dexamethasone for COVID, you're 70 kilograms, I'm going to multiply that by the higher end of NPH, which is 0.3. So that's 21 units of NPH for this patient. I'll give you 2/3 in the morning because you're not really eating meals, but that's mostly when your activity is happening and any hyperglycemia peaks will happening. And then 1/3 of it at nighttime. So that's 14 units in the day, 7 units at night. Common modifications for insulin regimens if you're transitioning off an insulin drip is to calculate how much insulin they've needed in the past 24 hours. This is a lots of math example for it. You don't need to memorize it now, but again, if you do the survey for feedback, you will get these slides emailed to you so you can have this as a reference for yourself in the morning. Divide the dose by half for safety is what we like to do to create your basal bolus 50-50 regimen. So for a patient who I calculated needed 125 units on a drip the day before, I ran that down to 80%, like 100, and then I divide that by half even further, and I say, I think you only need half of that insulin for real because you're out of that acute setting in the ICU.
8-unit short acting insulin. Remember that you don't have to correct perfectly, so your target blood glucose boost. There's new in the Journal of Medicine article that showed that if you target too low, you can actually have worse outcomes.
And that had lower mortality and fewer hypoglycemic events than in intensive sugar control group. And so what I remember from this talk, because I know that was a whirlwind, is these 3 points. For basal bolus correction, take the weight in kilograms, divide it by half. Half is long acting, half is divided into thirds for meals. For steroids, here are your short and long acting equations. For your drips, use a 24-hour total, divide it by 80 or lower it to 80%, and then divide it to your basal bolus, and only keep your sugars at a goal of less than 180. Take it away, Harsh.
Great, guys. We're just going to talk about a few more things. I want to kind of just go over the basics of understanding kind of like blood gases. And then I think my next topic has something to do with antibiotics. And then we have, I think, anemia with Akash at the end. I'll just try to point out the kind of the important points in these next few slides, considering that it's like 4:50, and I'm sure you guys have much better things to do on this Sunday. If we can move to the next slide, that'd be great. So the diagnostic approach to interpreting blood gases, remember these are arterial blood gases that we're going to be talking about over the next few slides. And this is kind of just the schema that I think about in my head. Is it like acidemic or is it alkalotic? What's the pH? Is it above or below 7.4? If it's below 7.4, then I look at the PaO2 or the partial pressure of the carbon dioxide and of the ABG that I get. And if it's above 40, I'm thinking that it's a respiratory acidosis. And then if I think it's below 40, I'm thinking of a metabolic acidosis. When I see a metabolic acidosis or I'm concerned about a metabolic acidosis, I'm calculating an anion gap. And I'm sure you guys remember, it is sodium minus bracket calcium plus bicarb and bracket is equal to your anion gap. If it is less than 12, we're thinking non-anion gap metabolic acidosis. If it's greater than 12, we're thinking anion gap metabolic acidosis. Again, on the other side of it, for alkalosis, we're thinking pH is above 7.4. We're looking again, still looking at the partial pressure of carbon dioxide in the arterial gases. If it's above 40, we're thinking an alkalosis, metabolic alkalosis. If it's less than 40, we're thinking a respiratory alkalosis. I think one step is, understanding what are we looking for? There's acidosis versus alkalosis, but understanding the differential of each of these is also very important. If we can go to the next slide, that'd be great. So these are my differentials for like these things that I think about when I'm thinking about these different kind of acid-base issues, starting with respiratory acidosis. At the end of the day, it has something to do with hypoventilation, and we're not ventilating the lungs as much as we should be. And that can be caused by like neuromuscular disease, drugs like opioids, or underlying diseases, lung diseases like COPD or asthma. On the other side of it, respiratory alkalosis has to do with hyperventilation. So things that would cause you to be breathing too much, or with an increased respiratory rate. We think of things like CNS disease, iatrogenic causes, like when people are on ventilators and we've like increased the respiratory rate too much, or patients who are pregnant also have a baseline respiratory alkalosis. Anion gap metabolic acidosis. This was the step one sort of acronym that I use, MUD piles. I still use it to this day when I'm thinking about anion gaps. I kind of go through my thoughts, and honestly, like it ends up like being like uremia versus DKA versus lactic acidosis for most patients. These other things like methanol, propylene glycol, INH, iron, and then aspirin is also salicylates, are kind of like much more rare. They do happen, but you kind of have other kind of history clues, kind of thinking about those. So like really when you're thinking about anion gap metabolic acidosis in the inpatient setting, you're really thinking about uremia, you're thinking about DKA, and you're thinking about lactic acidosis. For non-anion gap metabolic acidosis, this was the same, like this is the same step one acronym that I used when studying for step one. It was use part, and it really has to do, comes down to like diarrhea and extra chloride, because urinary division, small bowel fistulas, and pancreatic fistulas all are just excess chloride getting into your blood system. Extra chloride, the most common cause is just normal saline. When we give fluids to patients, it has chloride in it and can cause a non-anion gap metabolic acidosis. The most important one to know clinically is like diarrhea. Patients having diarrhea will lose, will kind of lose bicarb that way and cause a non-anion gap metabolic acidosis. Other important ones to kind of have in the back of your head are Addison's disease and RTAs, and then there's obviously some drugs that are listed there as well. Metabolic alkalosis, I think it's kind of opposite as non-anion gap metabolic acidosis. It's basically getting rid of H ions. So like vomiting, GI suctioning, diuretics, and like kind of these rare renal diseases, Bartter syndrome, Goodell's and Little's. So, you know, interpreting the pH is really important, and then kind of differentiating kind of what we're looking at based on kind of the partial pressure of carbon dioxide in your arterial system will kind of give you an idea and a differential for what you might be looking at clinically. But we can just hit the next slide. And, you know, very rarely do these like base disorders or acid-base disorders kind of happen in like unilaterally. They basically can, you know, happen on top of each other. You know, our body has some compensation mechanisms to sort of, you know, when someone is breathing really high, we start losing, you know, trying to compensate through our kidneys. So, you know, there's expected compensations, but there's also like overcorrections when we think there's a secondary acid-base disorder going on. Just like very quickly, we have Winter's formula to kind of, when we have primary metabolic acidosis, we want to see if there's an overlying respiratory acidosis or an overlying respiratory alkalosis. There's a similar formula for metabolic alkalosis that's listed there. When you do have an anion gap acidosis, it's kind of important to see if there is an on-top non-anion gap metabolic acidosis. So you will calculate a delta-delta, basically taking the difference in your anion gap and your difference in your bicarb, which you would get from like a Chem 7, to see if there's an on-top non-anion gap metabolic acidosis. For primary respiratory issues, you want to see if it's chronic or not chronic, and it's basically knowing that for every 10-point difference in your bicarb, which you get from your Chem 7, there should be a 0.08 change in your pH if it's acute, or in a 0.03 change if it's chronic. And you know, those are the main takeaways that I want you guys to get from this. And just understanding that, you know, there's usually more than one acid-base disorder going on at a single time. And you guys can, there's like med calculators, which you guys can just plug in the numbers into to kind of figure these things out. If we can go on to the next thing, for antibiotics, again, very briefly, I just want to go and talk kind of about general broad strokes of antibiotics. If you don't mind hitting the next slide for me. So I think about antibiotics kind of in this sort of like basic diagram sort of way. I kind of look at the kind of the left side of the screen where it says like penicillins and aminopenicillins, cephalosporins, and then it kind of goes into your kind of heavy hitters like the monobacterium, the quinolones, the amino acids. So what I just want to mention, there's like escalating levels of antibiotics, and you go from gram-positive coverage to increasing coverage into gram-negatives into anaerobes and atypical coverage. So your penicillins, you're going to have very limited gram-positive coverage. Really just like streptococcus is what you will cover with penicillin. And then as you kind of increase, you have increasing coverage of your penicillins with anti-staphylococcal, so nafcillin, oxacillin, you get more and more increasing coverage. And then ampicillin, amoxicillin, you have increasing kind of negative gram coverage there. And that's just to kind of point out for the rest of this sort of diagram is that as you get increasing increasing antibiotics, you're going to have kind of increasing broader coverage. And I think it's more important to kind of understand the broad strokes of it than understand that, you know, nafcillin has a gram-positive coverage while ampicillin has gram-negative coverage. And it's less important to understand that, like, you know, what specific bacteria are kind of covered from that, because you could always look that up. And then same with the cephalosporins. The first two generations have really good, gram positive and gram negative coverage, but as you keep going through the generations, you have increasing gram negative coverage. So like cephalosporin is going to cover less gram negatives than something like cefepime. Kind of going down, just want to point out a few other things is that important bacteria to consider when you're picking antibiotics is one is Pseudomonas. And it's important to know which antibiotics cover Pseudomonas because it's a pretty common infection that we have, but we have very limited bacteria that can cover it. And it really comes down to quinolones like Cipro, monobactums like meropenem, and like Zosyn and cefepime. And those are like the handful of bacteria that we have to think about when we're thinking about Pseudomonas driven infections. Otherwise, there's some kind of, the other antibiotics that we think about, tetracyclines and like metronidazole cover like other things that we don't always think about. So like doxy and azithro are really good atypical coverage. And metronidazole has really good anaerobic coverage because not all, bacteria, a lot of the early penicillins and the early cephalosporins don't have really good anaerobic coverage. If we can hit the next slide. I think, it's less important to memorize like what antibiotics cover what organisms, but it's more important to know which infections are caused by what organisms, because then it's easier to kind of pick your antibiotic regimen. These are like 7 or 8, like the most common infections that I think of when we treat patients like as an inpatient. Meningitis, we learned very much that, strep pneumo, Neisseria meningitis are like very common organisms that cause that. And just starting a person like empirically on the right coverage is always going to be, at least in adults, ceftriaxone, vancomycin, and ampicillin. CAP and VAP and hospital-acquired pneumonias. You can probably get away with covering most pneumonias with ceftriaxone and doxy. If you're concerned or they have risk factors for having hospital-acquired or ventilator-associated pneumonia, you want to increase to Pseudomonas and MRSA coverage, which is piptazo and vanco. Intra-abdominal functions, if you're treating someone empirically for an intra-abdominal function, whether it's like gallbladder, whether it's colitis, a really good coverage is ceftriaxone and metronidazole versus just piptazo. So piptazo does have anaerobic coverage, so it's just important that you don't need to add on metronidazole when you're covering solely with piptazo. Cellulitis, most organisms are, MSSA, MRSA, streptococcus. So you want something with really good gram-positive coverage, and those include like first generation, second generation cephalosporins like Keflex. But you also do want to, make sure if person's at risk for MRSA, you having antibiotics that cover MRSA. So that's Bactrim, Doxy, vancomycin. UTIs, I treat them differently as an outpatient versus as an inpatient. These are not like antibiotics that we had talked about previously, nitrofurantoin, fosfomycin, Bactrim. These are common things to cover these sort of gram-negative organisms. But when they're inpatient and I'm treating a UTI, I kind of tend to go with the heavy hitter, ceftriaxone, vancomycin, to be honest. Endocarditis, if you're treating something empirically without any like sort of organisms that you know about, we will sort of think about, starting them empirically on vancomycin and gentamicin to kind of cover the HASEC and organisms with gentamicin. And, vancomycin, very well known to be covering MRSA, but it also covers streptococcus and, non-MRSA MSSA. And then osteo, guideline treatment is vancomycin and ceftriaxone until you have culture data. So again, important to do that. I would also mention with osteomyelitis, about 10% are from, Pseudomonas or gram-negative organisms. So it's not wrong to pad people on, instead of ceftriaxone, piptazo, just to cover those gram-negatives. I know that was really quick. I'm happy to answer questions later. I just want to make sure you guys continue on time and fill out the form. Thanks.
All right, guys, so I'm going to bring it home here with going over anemia very quickly. Perfect. So I'm going to talk about anemia. you guys will work up a lot of anemia in the hospital, and I think it's important to have a framework to go through it. So I'm going to go through a couple slides and then finish with an algorithm at the end. So first thing I like to do is when I look at someone's hemoglobin, one question I have is this acute? Is this acute on chronic? So is this something new? Are they always low, but they're running lower? Or is like kind of what the trend is. And then after that, I like to look at something called the MCV, which you guys probably remember learning, the mean corpuscular volume. So that's sort of the size of the cells. And so low, normal, and high, you want to think of your numbers as anything less than 80 on the MCV is low. Normal will be about 80 to 100, and then anything over 100 is high. So that's how you're going to break things up as. So just some basic things like low MCV, iron deficiency is like classic thalassemias. Normal, your acute blood loss. Is there some chronic disease, especially renal? Sometimes early iron deficiency, early B12 and folate can have normal. And then this is where your sickle cell, your liver disease patients. And then your high MCV, these are patients we're taught very commonly that have your folate, B12, your chronic liver disease patients, your myelodysplastic, and then medications as well. A lot of them work by folate deficiency. One other thing that I like to use is like an RDW. I think, there's many different things you can see on this slide, like a low and a high. And again, that tells you the spectrum of how the size of the red blood cells will vary. So like high RDW means you'll have small cells, big cells. That is very classically associated with iron deficiency. Some of these other things can have that as well. And if you're going into hematology, you may get more nuance like that. But I think the classical thing for high RDW to think about is iron deficiency. So again, MCV, your RDW. Then one of the next things you'll order is a reticulocyte count. So you want to see if the cells, when the hemoglobin is low, is the bone marrow trying to proliferate and respond to that? And the thing you want to ask is it appropriately responding or is it not responding? So situations where people are not responding is where a reticulocyte index, which there's a calculation to do, is less than 2%. That's often set on the lab, or if the absolute count is less than 100,000. So these are like your hyperproliferative anemias. So people with renal disease, chronic anemia of chronic disease, medications, specifically any myelosuppressive medication. So again, your chemotherapies, iron deficiency will have a low reticulocyte count. And then mechanisms where there's difficulty with cell maturation, so B12 folate in particular, as well as sideroblastic anemia. Your reticulocyte count being high, so this is where you think of, anemias that have a destructive process. So your hemolytic anemia is people losing blood. Are they appropriately responding? So any hemoglobinopathy, any immune hemolytic anemias. Sometimes antibiotics or infections can cause hemolysis. There's mechanical hemolysis, like if they have mechanical valves, and then any membrane abnormalities like hereditary spherocytosis and some of these things. So to put this all together, I have this algorithm here, which I took from one of the annals papers you could see at the bottom. So basically you want to, just first see, does your patient fall into the anemia for man and female? And you can see the cutoffs here. And your labs, you're going to, you kind of can see the different entities, but the thematic labs, you're definitely going to order for any patient with anemia or a peripheral smear. You're going to get reticulocyte count and then iron studies. So that's kind of your framework. But this framework here, you'll see various ones, starts with the reticulocyte count. So you have to ask, is it sort of a regenerative? So is there a response or not a response? And if it's not a response, then you can see you'll go by the MCV to separate, is this microcytic, normocytic, macrocytic. And then if it's microcytic, you think about iron. So you check your iron studies and you see what those show. If they're low, and here's some of the cutoffs here, you'll see iron deficiency anemia. And then if it's not, then you have to think about things like, is this chronic disease? Is this infection? Is there hemoglobinopathy? Other type of things. Normocytic, B12 folate, again, can sometimes present early like this. Iron can as well. So again, these aren't cold, hard cutoffs. A lot of things will overlap, but I just want to give you guys a basic framework. look at their creatinine, those kind of things. And then you want to contextualize it to the patient. Again, infections, renal failure, any endocrine disorders, and so forth. And then macrocytic, B12 folate, thyroid as well can present like this. And then, contextualize clinically, are there any myelodysplasias, medications, things like that. And then for your regenerative anemias, those where the reticulocyte count is high, is the patient hemolyzing? Are they bleeding somewhere? Those are kind of your two questions. So I'm going to stop there and see if there's anything I can answer.
Hi, everyone. I want to thank you all for coming today. I want to especially thank our 5 resident speakers who have given incredible, concise summaries of these very high yield and practical topics. We're going to end the boot camp now.